Chapter 2: Patient and Family Response to the Critical Care Experience. Nurses play a unique role in addressing the needs of patients and families in a busy and complex environment. Ongoing research into the experiences of critically ill patients and their families consistently supports the premise that nurses must consider the patient and the patient's family holistically. Critical care nurses assume an advocacy role in caring for patients and their family members who have life-threatening illnesses and problems. What they mean by this is keep in mind you are not just treating that patient, you're also treating that patient's family. Not only is that patient going to be very, very ill in the ICU setting, the patient's family is going to be very scared as well. Think about the critical care ICU environment. Now, how would you describe that intensive care unit? It's going to be very busy. Along with sights, sounds, people are going to be moving very quickly. You're going to have a lot of alarms going off, a lot of machines. There's going to be a lot of IV pumps and medications running simultaneously. And all of this is going to create a very hectic environment, both for the nurse, but it's also not going to help the patients be at ease. They're already going to be very concerned with with the patient's health condition. They are not in the ICU unless it's a high acuity illness. And we need to keep in mind that both the illness itself as well as that fast-paced environment are both going to create a very stressful experience for the patient and their family. The critical care environment's designed for efficient, life-sustaining interventions. And the patients and family often have little advanced preparation for this. Think about all the new technologies and the environment contributing to the stress of that patient and their family. Also, what other issues, such as sensory overload, sensory deprivation? Unlike a medical surgical unit, many ICUs do not have that lights off period. This is going to be a very fast pace. The focus is on treating these acute illnesses and saving the patient's life, and rightfully so. But also think about the other things that go along with this, and that patients are going to get sensory overloaded very quickly. The lights are going to be constantly on. There's going to be a lot of noise 24/7 of people moving around, communicating, working with other patients, also in and out of that patient's room. They're going to have that loss of privacy with multiple caregivers and multiple people in and out of both the unit as well as the room. There's also going to be a lack of non clinical physical contact. These patients are going to be focused on treating that illness as the top priority. And many aspects of the critical care environment contribute to that sensory overload, the noise being the primary factor, as well as the lighting. This can result in adverse outcomes and the patients becoming extremely stressed. On the other hand, sensory deprivation may also occur, and this results in increased perceptual disturbances. And this can be treated with everything from visitors, photos, soothing music, and lighting. This adequate and appropriate exposure to light is a therapeutic modality for the health of both the patients and the clinicians. No, we don't want lights on 24 hours a day. That is creating sleep disturbances, sensory overload. At the same time, we don't want sensory deprivation either. We want to find that balance, and we want to treat the patient as a whole. We're both treating that acute illness, but we also want to make the patient as comfortable as possible to help improve their outcomes as well. Many modifications can be made in the environment to promote the patient's well-being, everything from noise reduction, lighting, new units that are being designed with industry standards to promote the patient's well-being for both patients as well as their families. Confidentiality can also be improved by designing a private place for communication with family members and closing the door during conversations that may be overheard by others. Privacy is going to be a top priority for these patients. The staff can also help minimize the noise level by avoiding excessive or loud talking, responding to phones quickly, and readily assessing alarms and IV pumps that may be going off. Noise reduction can also include things like acoustic tiles and designs, playing soothing music, and again, that private areas for communication. Also, adequate lighting, which includes natural lighting, along with a night-day synchronization to help keep their circadian rhythms running smoothly. For our first question, the nurse is caring for an older adult patient and attempts to reduce the risk of perceptual disturbances by which of the following interventions? A. Place the patient near the pneumatic tube station. B. Place the pictures of the patient's family within sight. C. Close all windows and shades during the day. Or D. Do not allow visitors. And that answer is obviously going to be B. Place pictures of the patient's family within sight. These non pharmacologic interventions can help provide cognitive stimulation while also orienting conversations, encouraging and the visitation of friends and family, as well as posting family photos within the patient's site and tailoring music or television to all help keep the patient stimulated, but also not in a way that would cause sensory overload. And as we said, that answer is B. Place those pictures of the patient's family within sight. And it's a very easy intervention, something we can do to help jog the patient's memory, help them remind them of loved ones, and also provide that light stimulation while they're dealing with their illness. In the case of critically ill patients, their responses may vary according to their age, developmental stage, prior illness or hospitalizations experiences, family relationships and social support, coping mechanisms, their own beliefs about life and death, spirituality, and variations among cultures. These different factors all influence the patient's response to that critical illness. Other studies have identified several things that patients recall about their critical care experience. Everything from difficult communication, pain, thirst, difficulty swallowing, anxiety, lack of control, and depression. They may also complain about fear, a lack of family visitors, feelings of dread, discomfort, difficulty sleeping, loneliness, thoughts of dying, or possibly even physical restraints. There is a combination of conditions that could collectively be described as post intensive care syndrome. And these would mean things like anxiety, agitation, delirium, and even leading to PTSD and further anxiety and depression. Let's talk strategies to support the critically ill patient. First is going to be an acronym, the ABCDEF bundle. And this is A, assess, prevent, and manage pain. B, both awakening and breathing trials. C, their choice of sedation. D, a delirium assessment, including prevention and management. E for early mobility, and F for family engagement and empowerment. In the case of orienting, we want to increase pleasant sensory, as well as reorient the patient every 2 to 4 hours. Directly address the patient, avoid discussing other information or patients, and place items within the room to assist with the orientation of that patient. And keep in mind, these tactics should be used whether or not the patient is sedated. In the case of promoting sleep, critically ill patients spend more time in light sleep. We want to bundle non pharmacologic interventions, as well as working to minimize any noise during the nighttime hours. We also want to focus on using appropriate lighting, such as allowing natural light in during the day and reducing the light levels at night. Quick quiz. The night shift nurse notes the patient has not been sleeping at night and alters the plan of care to implement which of the following interventions to promote sleep. Would that be A, getting the patient out of bed in the morning and placing them near natural light? B, minimizing alarms in the room? C, turning the lights off at night? Or D, bathing the patient in the middle of the night? And obviously, this is going to be a select all. Answers are A through C. Bundling non pharmacologic interventions, such as removing noxious stimuli, increasing comfort, and promoting day night cycles, are effective ways to promote their both sleep and rest. Also, positioning the patient near natural light during the day, reducing light levels in the patient's room at night, and minimizing noise during nighttime hours are other strategies to help keep their circadian rhythm in sync. I can't stress enough the importance of trying to bundle those non pharmacologic interventions. We want to disturb this patient at night as much as possible, as little as possible. So we're going to have to get vital signs. We're going to have to see and treat this patient. But doing as much as we can in bundles to give them rest in between these interventions is going to go a long way in helping that patient recover. In the case of family members, critical illness and injury affects the whole family, and these include things like uncertainty and loss of control. The environment can be very overwhelming as well. We want to work to provide shared decision making. And this is important because it occurs when both the patients and families collaborate with the critical care team. In the case of the Calgary Family Assessment, this is structural, including who comprises the family, decision makers and the spokesperson, as well as race, ethnicity, and other cultural factors. It may also incorporate developmental stages, tasks, and attachments, along with functional, such as how the family members interact with each other. There are various methods for assessing the family, though this Calgary Family Assessment tool provides cues to the structural, developmental, and functional aspects of that family. When helping the family cope, we want to provide assurance, remain near the patient, help them receive information, make sure that they're as comfortable as possible, and also having whatever support available that they would need as well. We also want to help promote coping strategies, determine the best way to communicate with the family based on their unique needs, and establish a partnership and build a therapeutic rapport with both the family as well as the patient. Next, we have the value mnemonic. And this is a useful tool to help provide nursing interventions. V for value, what the family tells you the values are. A is to acknowledge those family emotions. L's listen to family members. U understand the patient as a person. And E elicit questions from family members. We also want to communicate and updates on the patient's condition, anticipated treatments or procedures, and the patient care outcomes we're attempting to achieve. There may also be numerous nursing interventions that can be implemented to meet the family needs and reduce family members' anxiety or stress. Open visitation is one essential intervention. Children as visitors should take into account the developmental stage of the child and discuss the pros and cons of family visitation and family presence during procedures and codes. For our next question, which of the following interventions would not increase the family's knowledge of the patient's condition? That be A, closed visitation hours, B, family presence during invasive procedures, C, the teach back method, or D, a family conference within 28 to 48 hours of admission. And obviously, that answer is A, closed visitation hours. While there is going to be a need of some time where the family may not be able to be present in the room, we do want to encourage as much visitation as possible. That's not only going to help put the family at ease, but it's also going to go a long way in placing the patient at ease as well. When considering quality of life after critical care, keep in mind that outpatient post-intensive care syndrome is a very real condition, and that clinics are available for support. And also keep in mind that families may also require follow-up care. These family members have an increased risk of developing PTSD, along with that caregiver burden after a critical care experience. You need to be using your best clinical judgment, your best nursing judgment on who should visit the patient. How can that visitation be facilitated? And what factors could support the family presence during procedures and even resuscitation? Some key points include the critical care environment that can cause extreme stress and anxiety due to sensory overload and sensory deprivation. We want to work to reduce adverse outcomes by modifying noise and the exposure to light, as well as distressing physical experiences and memories that can result in post traumatic stress disorder, anxiety, and depression in the months following critical illness. Other key points include engaging the family in the patient's healing process by providing up to date information along with assurances. Keep in mind that family presence can contribute to the health and well being of the patient. We also want to focus on that multidisciplinary post discharge care that may be necessary to deal with a complicated recovery. But anyway, that's all we got for this chapter. I'll see you in the next slides.